of Clinical Cardiology at the University of Antioquia. Welcome to another session of Approach in Cardiology. It's an honor for me and for our cardiology group to introduce today Dr. Toby Rogers. He is an interventional cardiologist and associate professor of medicine in the Georgetown University, and also a scientific lead for structural heart disease in the MedStar Washington Hospital Center. He's going to, in this opportunity, the doctor will talk about some relevant aspects in the approach and management of thrombosis of mechanical valves. Doctor, go ahead with your presentation, and thanks for accepting our invitation.
Good morning, everybody, and thank you for inviting us to speak. My name is Toby Rogers, and I'm joined today by Dr. Cesar Soria, who until recently was a general cardiology fellow with us in Washington. He put this manuscript together with me, and he has just started his interventional cardiology fellowship in San Diego. So it is very early in the morning for him, but he got up early and is going to help me present this morning. So we're going to try and cover a topic which is challenging, but also devoid of any substantive clinical data. And that's one of the things that makes it challenging. As you can imagine, it's practically impossible to run randomized trials in the setting of mechanical valve thrombosis because of the typical types of presentations. But nonetheless, there is a lot of registry data and just clinical experience that I think we can all share to help us treat these often difficult clinical cases. So this morning, we're going to focus on these simple sections of instance and etiology, clinical presentation, diagnosis and imaging, and then focus most of the discussion, I hope, on management and how best to treat these patients. So with that, I'd like to hand off over to Cesar to move on. And Cesar, if you just say next when you're ready for a slide, and I'll move it on, okay?
Thank you, Dr. Rogers. To give you some background, valvular heart disease is a very prevalent condition in the world. It's estimated to affect more than 100 million people worldwide. The incidence and the prevalence of this condition has been changing and has been increasing. In the past, rheumatic heart disease used to take a larger percentage of this condition, and now we've seen over the years that this has been decreasing, while that of degenerative valve disease has continued to increase. In the United States alone, it's estimated that just short of 3% of the population is affected by this condition, and it's a lot more prevalent in those that are aged more than 75 years. And this problem is expected to only keep increasing with our aging population. Next. Today, there are a wide variety of surgical valves for treatment of valvular heart disease, with options ranging from bioprostheses and mechanical options, as you see on the right. Next. There are also a wide variety of options for transcatheter approach to treatment of valvular heart disease, as you see in this slide. Next. Nevertheless, despite the proliferation of all these different valve options, there is a continued need for mechanical valves, which you see here on your slide. This is particularly true for patients that may be young and require a more durable valve. And sometimes these are the only valves that are available for patients in different parts of the world where a bioprosthetic valve may not be a viable option. So you see here these three different designs. On your left, you see the ball and cage, which is the oldest model that was then updated or upgraded to the middle model, which is the tilting disc design. And then on your right side, you see the bi-leaflet model, which is the newest generation of these mechanical valves. Thrombosis of these valves is a non-complication because these valves require that patients take anticoagulation for the rest of their lives. And thrombosis can be a catastrophic consequence of mechanical valve, having a mechanical valve. I want to emphasize that this talk is focused on mechanical valve thrombosis, while prosthetic valves can have complication of thrombosis, but the focus of our paper was to discuss and explore the issue of mechanical valve thrombosis. Next. So the incidence of this problem is estimated at an annual rate of 0.1 to about 6%. This varies largely by valve design as well as the position, with higher rates seen in valves that are older generation, as well as valves that are in the tricuspid or the mitral position in comparison to the aortic position, as well as valves that are newer and are within the 90-day window of implantation. The reality, though, is that this incidence is very variable in the literature, and it's thought to be underestimated. You can see part of the reason why here on the guidelines. So the current society guidelines state that following an immediate post-implantation echo, a routine echocardiogram for these patients is not recommended. And really, the only recommendation is that when the clinician suspects or there are signs or symptoms suggestive of valve dysfunction, that is when you should get an echo on the patient. And this is likely then resulting in underestimation of this issue. Next. The etiology of mechanical valve thrombosis is multifactorial, as you see here, and related to several factors, including stagnation of blood, flow disturbance, and high shear stress that can precipitate cellular damage, platelet activation, formation of thrombus, calcification around the valve, as well as tissue overgrowth. There are also valvular surfaces that can be more prothrombotic, as well as a myriad of different patient factors that can increase this risk, including conditions like atrial fibrillation, severe left ventricular dysfunction, and other hypercoagulable states. Next. The clinical presentation of mechanical valve thrombosis encompasses a wide spectrum. On one end, it can be a simple incidental finding seen on an echocardiogram that a clinician may get for an unrelated reason to the valve. But on the other end, these patients can present in cardiogenic shock and extremis. Normally, these patients commonly present with a subtherapeutic anticoagulation, so a low INR. Patients and clinicians may notice absence of the mechanical valve clicking. There can be new murmurs on exam, as well as signs and symptoms of pulmonary edema, hypervolemia, and pulmonary or systemic embolism, including ischemic stroke as the first symptom. Next. On initial evaluation, it is important to make a distinction between valve obstruction that is caused by thrombus, which you see on your left, and pannus, which you see on your right. In general, thrombus is larger and more asymmetric. It tends to have a similar echogenicity to the surrounding myocardium. It's got a shorter duration from time from insertion of the valve to its malfunction, as well as a shorter duration from the symptom onset to clinician making a diagnosis, and a lower rate of therapeutic anticoagulation. Contrast this with pannus formation, which, again, in general, tends to be more circumferential. This abnormal tissue growth tends to grow inward from the annulus of the valve, and it's more commonly found in valves that are in the aortic position. Next. Before moving on to this next segment of diagnosis and imaging, I would like to just take a short pause and ask if there are any questions at this stage.
No question, Dr. Cesar, at the moment, and we got another session of questions at the end of the presentation, so there's no problem.
Perfect. So we will continue. So for this next segment on diagnosis and imaging, our guidelines state that when clinicians suspect mechanical valve thrombosis, an urgent evaluation with echocardiogram, fluoroscopy, or CT imaging is indicated to assess the valve function, leaflet motion, and as well as confirming whether or not there is thrombus forming on this valve. Note that these guidelines are very limited. This is really all the guidelines say about this issue. They do not provide any algorithm or roadmap to help clinicians evaluate patients and establish the diagnosis. And this was the main reason for us writing this review paper. Next. So I will discuss in detail the three main imaging modalities that are used to help establish a diagnosis of mechanical valve thrombosis. The first and most common being echocardiography, also fluoroscopy, and cardiac CT. And I will review each one of these in more detail, starting with echocardiography. So 2D and 3D echocardiography can give you a qualitative assessment of appearance of your valve, mobility of the leaflets, the presence and size of thrombus, if there is any, and importantly, the expected versus your observed opening and closing angles. And I will touch a little bit more on that shortly. Next. This is an example of a transesophageal echo that is imaging the a mechanical mitral valve. And you see here on your left how the posterior leaflet of this valve is immobile, while the anterior leaflet is moving freely. And this is further confirmed when you do 3D echocardiography on the valve. You can appreciate how there's really only one valve orifice that opens, while the other one was not. Next. As I mentioned earlier, each of these valves have an expected opening and closing angle that varies depending on the manufacturer of the valve. These angles can be measured using echocardiography and then compared to what is expected to be the angle based on the manufacturer, as you see on this table. This is most easily done for valves that are in the mitral position, and to a lesser extent to valves in the aortic position. Next. The addition of color Doppler echocardiography can be very useful in the evaluation of these valves. Color Doppler can help visualize whether or not there is flow across the valve, the presence of turbulence across it. You will see aliasing of your color Doppler, as you see here in the video, as well as the presence of regurgitation across the valve, which can be either paravalvular or transvalvular. And it's important to make that distinction because they can be caused by different things. Paravalvular regurgitation is caused by suture line disruption due to mainly surgical error, suture failure, annular disruption, or endocarditis, whereas transvalvular regurgitation is more caused by impaired motion of the valve leaflets due to vegetations, pannus formation, thrombus formation that can interfere with the complete closure of the valve. Next. Spectral Doppler, in addition, can be used to help evaluate your transvalvular gradients. Mechanical valves, in general, have a higher transvalvular gradient compared to healthy native valves. This expected gradient is specific to valve type and size, similar to the conversation we had about the opening and closing angles. But in general, valve obstruction is defined as a mean transvalvular gradient that has increased by more than 50% when compared to the echocardiogram that was obtained immediately after the implantation of the valve. And more specifically for aortic prostheses, it is defined as an increase greater than 10 millimeters of mercury when compared to the post-operative baseline that I just mentioned. Next. Here's an example of that mechanical mitral valve I mentioned earlier, where you see here that the transmitral pressure gradient is severely elevated with a mean pressure gradient of 24 millimeters of mercury. Next. So now I will shift and discuss fluoroscopy, which is a different imaging modality that can be used to help evaluate these valves. This imaging modality allows for direct visualization of your leaflets, as you see here on this video. It is a good option for determining these opening and closing angles that I mentioned earlier. If you're able to obtain an orthogonal view where you can see the valve like you see here in the video, then you can clearly appreciate the leaflet motion. Prior studies have shown that this fluoroscopy has good sensitivity as well as specificity for prosthetic valve obstruction, both for the mitral position as well as the aortic position. And importantly, this is a modality that you can use to help monitor patients as you follow them across their treatment course, whether that be anticoagulation or lytic therapy. Next. One of the limitations I didn't mention about fluoroscopy is the ability to obtain an orthogonal view. Sometimes the valves are positioned in such a way that you really cannot get a good image of these leaflets like I showed in the video. And so that is one of the main limitations of fluoroscopy. Another imaging modality that you can use to kind of bypass this is cardiac CT. Cardiac CT does not have this limitation by, the attainable angles that the C-arm is able to get. Prior studies have shown that it's got good concordance with fluoroscopy. And you have the added benefit of these attenuation values on CT that can help differentiate whether the issue is due to thrombus versus pannus, as I mentioned in the earlier slides. You can use the Hounsfield units to help make that distinction. In general, it has been shown that masses that have Hounsfield units less than 145 more likely represent thrombus, whereas Hounsfield units that are greater than 145 more likely represent pannus. And studies have also shown that when these patients are treated with thrombolytic therapy, they are more likely to achieve complete thrombolysis when these masses have Hounsfield units less than 90 versus anything higher than that. Next. And this is an example of a patient that we have seen at our institution that had mechanical valve thrombosis and was followed with cardiac CT. And you can see how powerful this imaging modality can be in helping you evaluate these valves, because you can really obtain every angle that you would like and measure all the opening and closing angles. Next. All right,
Thanks.
so now
that's a fantastic overview, and I'm sure there'll be some questions at the end. One little tip, if you're using fluoroscopy and you are struggling to get that orthogonal view, is to remember that the patient doesn't have to lie on their back on the table in the cath lab. If you're just doing fluoroscopy, obviously we always lie them on their back when we're doing interventional procedures. But if they're just on the table for fluoroscopy, you can try moving them, and sometimes just making them roll onto their side, either the left side or the right side, will allow you to get to that fluoroscopic angle that you just couldn't get the C-arm to go to with them just lying flat on their back. And sometimes that is necessary, particularly if you have a patient with two valves, for example, aortic and mitral, and you're trying to get good orthogonal views to appreciate the leaflet motion of both. So let's move on to management of these patients. And again, I think it's important to start by just saying that this is an area where we do not have the sort of rigorous randomized trial data that we'd like, but that doesn't mean there is no data. Obviously, if you have a patient who presents with mechanical valve thrombosis, there are a number of treatment options available. If it's an incidental finding, they're completely stable and their INRs are a bit subtherapeutic, then it stands to reason that it's that just optimizing anticoagulation is a reasonable first step. And we'll talk a little bit about the optimal recommendations for anticoagulation Cesar alluded to thrombolysis, and we'll talk a little bit more in depth about that and what different thrombolytic regimens have been tested and which one we prefer to use at our institution. I'd be interested to hear what you guys do locally as well. And then obviously, if the medical therapies fail, then replacing the valve is often the only alternative, although we will touch on our talk a little bit later on possibilities for transcatheter percutaneous approaches in selected patients. So again, just to go back to the guidelines, what do the guidelines say in terms of treatment? Well, this is the American guidelines. For patients with a thrombosed left-sided mechanical prosthetic valve who presents with symptoms of valve obstruction, urgent treatment with either slow infusion, low-dose fibrinolytic therapy, or emergency surgery is recommended, which is true, but I would argue kind of unhelpful, because actually, you know, which patients do you do one, which patients do the other, when do you make the decision to escalate? And the guidelines really don't help in that regard. So hopefully we can shed some light on that with the next few slides. First of all, it is important to just remind everyone that anticoagulation for mechanical valves is still currently limited to warfarin and heparinoid drugs. Of course, we would all love if we could use the newer direct oral anticoagulants, but they are not indicated for mechanical valves. And several studies now, including of some of the more modern mechanical valves, have shown worse outcomes with higher thromboembolic rates. And so at the moment, it is absolutely not recommended to use a direct oral anticoagulant for a mechanical valve. It is reasonable, like I mentioned, to just use warfarin and heparin if you have incidental findings of thrombi on the valves, particularly if the patient's asymptomatic. In terms of recommendations for the aortic mechanical valves, in the absence of thromboembolic risk factors, target INR of 2.5 is recommended. If you have risk factors and if you have an aortic valve, or if you have a mitral mechanical valve, irrespective of the risk, then the target INR recommendations are higher. Low-dose aspirin can be considered if you have a concurrent indication for antiplatelet therapy, such as coronary artery stents or peripheral vascular disease. And I just reiterate again, the direct oral anticoagulants are presently contraindicated. And I doubt that's going to change unless there is a fundamental design change with these valves. So let's talk about thrombolysis, which is usually the first-line therapy if a patient presents with mechanical valve thrombosis. There have been a number of registries, and we're going to go through those in a moment. But again, I think it's important to acknowledge that these are not randomized trials, and so we just have to interpret the data that is available. So this first study, the PROTE registry, it was an international registry of 107 patients with suspected mechanical valve thrombosis. You're going to see that most of these registries and studies are small numbers of patients. This is still a relatively rare phenomenon, thankfully, and it is hard to get these, to collate these together and to build bigger registries. In this study, TE was used before thrombolysis, and thrombus area and prior stroke, meaning thromboembolic events, were independent predictors of increased complications post-lytic. So if your patient comes in with mechanical valve thrombosis as a very large thrombus and they've already had a thromboembolic risk event, then you've got to think very carefully before you give them lytics, because there is a higher risk of it happening again. Some of the other registries that I mentioned have looked at comparing different thrombolytic regimens. Obviously, there are different drugs, streptokinase and TPA, for example. There are also different doses and different the speed at which you give these. So this was a study comparing outcomes according to drug, but also the speed, so rapid or slow infusion, high-dose TPA, half-dose TPA, or low-dose TPA with or without bolus. And essentially, the patients who received the low-dose TPA without a bolus had no difference in mortality, but had fewer non-fatal major complications, which would suggest that the less aggressive low-dose trickle the lytic in rather than bolusing, and giving it rapidly is safer and has the same efficacy. So this ultra slow thrombolytic therapy regimen has been tested further in a study of 114 patients who received this ultra slow infusion, so 25 milligrams of TPA given over 25 hours, showing a 90% success rate with very low rate of complications, specifically mortality, bleeding, and major embolus. So at least at our institution, we've adopted this ultra slow regimen, 25-hour infusion of 25 milligrams of TPA without a bolus. We perform transesophageal echo regularly throughout the infusion. And the infusion can be repeated if it looks like it's working. So if you're seeing improvement, maybe the leaflet hasn't completely freed up, but the hemodynamics are looking better, then it's reasonable to keep it going. You have to be a little bit careful that if you are, for example, pausing the lytic therapy to reassess before starting again, that you cover the patient with heparin during that pause in between. And then that you, if you're going to give a second regimen, that you hold the unfractured heparin, wait for the APT to come down, and then restart the TPA. And of course, if you get a good result, meaning the leaflets start moving again, the hemodynamics normalize, then you obviously have to bridge the patient with unfractionated heparin until you get them therapeutic with warfarin again. One of the big questions is always, well, when do you choose thrombolytics and when do you choose surgery? This was a multi-center observational prospective study of 158 patients. I think that's important. Again, I sound like a broken record, but this was not a randomized trial. These patients no one tossed a coin and said, let's send half the patients to surgery and half for lytics. But they followed these patients who were at the individual physicians at the site's discretion, either treated with lytics or with surgery. And they used in this study the slow or ultra slow infusions of low TPA. And what they saw was that in the patients who received the lytics, there was a 90% success rate. There was a substantially lower rate of major and minor complications. And at 3 months, the mortality was much lower. Now, can we completely say that that is down to the treatment and there is no element of confounders because the sicker patients maybe were referred for surgery? No, we can't. But I think on the whole, it gives us confidence that unless the patient is truly in cardiogenic shock and deeply unstable, I think that starting with thrombolytics is the right way to go. Starting less invasive, see how they respond, and then escalate as necessary, rather than rushing to surgery as a first line, because it looks, at least in these series, that thrombolytics is effective in the majority of patients. So let's just go through a couple of cases. These are all patients who have been treated at our institution. We'll keep the histories nice and short so we can focus on the imaging. This was a 43-year-old woman with a 25 millimeter mitral valve and a 21 millimeter mechanical aortic valve, both mechanical valves. And she presented with heart failure. So here is the TTE of her aortic valve and the mitral valve. You can see on both valves, there's turbulence, there are higher gradients. Here is the fluoroscopy, and this is a nice picture actually, because it just shows how, in this view at least, we have the aortic valves in the nice orthogonal view. We can see, this is the valve at the top, obviously the smaller of the two. We can see one leaflet seems to be moving pretty well. The leaflet on the left side of the screen is barely moving at all. The mitral valve in this view, it's actually quite hard to appreciate what's happening with the leaflets because we're looking at it end on and not side on in the orthogonal view. And in this patient, I think if I recall, it was actually quite hard with the patient lying on her back to get a nice orthogonal view of the mitral valve. And in this case, as you can probably tell from all the leads and the fact that she has a pulmonary artery catheter and she was quite sick, and so rolling her around on the table to get those orthogonal views, like I mentioned, was not an option at this point in time. So she was treated with the low-dose TPA regimen, and you can see here improvement of the aortic valve leaflet motion. You can see here on the left, one of the leaflets is moving fine, the other one is definitely moving better than it was on the fluoroscopy. On the mitral side, obviously still some restriction of one of the leaflets. But so we persevered with the thrombolytic in this patient. Here's the improvement in the gradient from 66 millimeters of mercury down to 18, so improvement on the aortic side. And with just perseverance in the lytics therapy, the mitral valve freed up as well. So here's just side by side the two fluoroscopy, and now you appreciate what we weren't really seeing. We couldn't really tell on the first picture on the left. You can see the difference in the appearance when you look end on the valve on the mitral. So on the left, now we realize just how restricted those leaflets were, because on the right, now that they're moving, we can clearly see the opening and closing, even though we're looking at it end on. So again, just to point out how misleading the picture on the left can be if you can't get to the side view, but how reassuring the fluoroscopy is on the post-treatment.
Okay, so I will discuss this next segment. Dr. Rogers mentioned the different therapeutic options that exist and are recommended by the guidelines. Again, these are anticoagulation, thrombolytic therapy, and surgery, which we will get into more in the next few slides. But he also mentioned if there is a role for a transcatheter approach. And we've had some experience with that at our institution. Percutaneous manipulation of these valves can be considered to help relieve these stuck leaflets. In particular, it can be a potential option for patients that have failed thrombolytic therapy or may have a contraindication to thrombolytic therapy, for example, recent intracranial hemorrhage or presentation with a supratherapeutic INR. It can also be an option for patients that are in cardiogenic shock and severe hemodynamic instability that makes it difficult to take these patients for a surgery. And it can also be an option for patients that have an unacceptably high surgical risk. I want to make the point that, you know, a transcatheter approach may be feasible. However, it may not be a definitive treatment, but you can consider this as a potential bridge in order to get your patient to that next treatment, whether that be surgery or something different. Small case reports have shown it to be a safe and effective option. Next slide. Here's a table that we included in our paper that really summarizes what is in the literature about this treatment approach. So what we found is really there are only 4 case reports and 1 small case series. In total, there are only 8 patients that have been reported, at least that's what we found, that really talk about this transcatheter or percutaneous approach. And you can see here that most of these were in the mitral position. There was 1 patient that had a valve in the aortic position. And the case reports talked about using different catheters and devices found in your catheterization lab to essentially relieve or open up the leaflet. And at least in these reports, they did not report any significant complications. Again, I want to emphasize that this approach is not really driven by any robust data. There are no randomized studies. These are very small case reports, but it can be an option when lytics or surgery is prohibitively risky. And I'd like to share a case that we had at our institution as well. So this is a 40-year-old woman who presented with cardiogenic shock. She had a known mitral mechanical valve of 29 millimeters. And importantly for this case, she actually presented with a supratherapeutic INR. If I recall, her INR was around 4, which made thrombolytic therapy a contraindication. Next. This patient received a transthoracic echo initially, which then progressed to getting a transesophageal echo to confirm the suspicion of mechanical valve thrombosis. And these are the images that I showed you earlier. You see here on the left, this transesophageal echo of the mechanical mitral valve. You see how one of the leaflets is free and the other one is very restricted. You see turbulent flow across the valve on the left. And then when we do 3D echo reconstruction, you can clearly appreciate how this valve is not fully open. You only see one of the valve orifices opening, whereas the other one remains essentially closed. Next. I showed you this slide earlier. This was the transmitral pressure gradient. As you can see here, was severely elevated with a mean pressure gradient of 24 millimeters of mercury. And so before I take you through these steps, I want to emphasize that there was a big discussion about what to do about this patient. There were clinical cardiologists, ICU physicians, as well as cardiac surgeons involved in the care of the patient. And it was a decision to whether to do thrombolytic therapy, which again, we said was not an option because of her supratherapeutic INR, which made her bleeding risk very, very high. And surgery felt that her risk for surgery was prohibitively high. The patient was requiring inotropic support and was continuing to worsen. And so they felt like she would not survive a surgery. And given the situation that we were in, we then decided to approach the treatment via this transcatheter therapy that we've been mentioning. So I'll walk you through what we did here in the cath lab. In the cath lab, she was taking, and the first thing we did was place a cerebral embolic protection device, which you do not see here. That was a filter that is placed in the brachiocephalic and the left carotid arteries in order to prevent any potential debris that may come off of the valve and preventing any of that debris from reaching the brain and resulting in ischemic stroke. You see here on the left, the first video that we obtained access into the left atrium via a femoral transvenous approach, and then a transeptal puncture from the right atrium into the left atrium in order for us to access the left atrium and see the mechanical valve in the mitral position. You see the video on the right here. Now that we have an orthogonal view, again, you can really appreciate how the anterior leaflet is free and the posterior leaflet does not move. And what we first did was place a deflectable sheath that you see here in the fluoroscopy video. And we had that sheath facing the valve. We then proceeded to try and just open the valve by pushing against it. This was a small catheter that was fed through the sheath. And as you can see here, we're trying to push on that leaflet, but unfortunately, the leaflet does not open. We then switched and tried a different approach. We thought to use a smaller structure. In this case, we tried to use a stiff 035 wire, again, trying to open that leaflet. But as you can see, every time we push on it, the leaflet does not move and the entire system that we're using gets pushed away because the leaflet does not want to open. We then switched to a different approach and went with a smaller guide wire. And you see here on the left how we are able to pass a stiff 014 guide wire. This guide wire was fed between the annulus of the mitral valve and the leaflet that is restricted. And that was confirmed on our 3D echo. And you can see here very beautifully how it went through that orifice that was not opening. We then proceeded to do a balloon valvuloplasty using progressively larger non-compliant coronary balloons. You see one here on the left a smaller coronary balloon to open up that leaflet, and then a slightly larger balloon, until finally we were able to free this leaflet. And you see here how it has near normal motion, and that is also confirmed on echo. Now you can appreciate how this orifice is now opening, whereas before it was essentially closed. This patient had pretty remarkable and pretty immediate hemodynamic improvement. In the cath lab, she was being monitored, and her pulmonary capillary wedge pressure significantly reduced. Her mean left atrial pressure also significantly reduced. She was taken back to the ICU and monitored with sequential echoes, and the transmitral pressure gradient continued to improve. This is the image that we got at the end of that case. As I mentioned, this patient had a cerebral embolic protection device, because what we were essentially doing is forcing the valve to open, and that meant potentially dislodging any thrombus on that valve into the systemic circulation. And so the biggest fear was that we would cause a stroke. And you see here how we were able to capture some of that debris when we opened the valve. This patient did remarkably well, and she was actually followed with sequential echoes until the pressure gradient across her mitral valve completely normalized, and she actually did not require any other kind of therapy. And she was actually discharged home and doing clinically very well.
So just to finish up, when should we consider surgery? Well, obviously surgery provides the opportunity to replace a mechanical valve, particularly if it's one of the older, more thrombogenic designs, such as the ball cage or the tilting disc. It allows for definitive diagnosis if you're not sure this is thrombus or pannus, and obviously replacing the valve is a treatment as well. The decision as whether to replace with another mechanical valve or to put in a bioprosthesis is multifactorial. Of course, if the reason why the valve thrombosed was because there was a mistake and the warfarin wasn't taken, or it was suspended for another procedure, and you can't really blame anything else, then it's not unreasonable to put in another mechanical valve, particularly if the patient is young. But of course, if there are bleeding problems or no obvious reason why that valve thrombosed in the first place, then it probably makes sense to switch to a different valve. Or if the patient is just at an older age now where a bioprosthesis makes sense, then I think that's the way most surgeons would go these days, particularly now that we have strategies to replace failing bioprosthetic valves with transcatheter valves in the future if it was so needed. It is worth pointing out that the sicker you present is for surgery, the worse you're going to do with surgery. It seems obvious, but it's important to remember. And this is one of the reasons why I think the less invasive approaches, such as starting with thrombolytics as a first line, just makes sense. One last case here, just to sort of close the loop. This was a 53-year-old woman who had a mechanical mitral and mechanical aortic valve. She presented in cardiogenic shock. Initially, we tried the low-dose TPA, but really just didn't change the hemodynamics. Here you can see the mobile leaflets on the esophageal echo. She had a lot of turbulence and elevated through the mitral valve, elevated gradients. One thing that was of great concern to us was she had this appearance of a mobile mass on the aortic valve with elevated aortic valve gradients. And so, yes, there were several reasons why we did not consider transcatheter on this, but this was certainly one of them, that we felt that the risk of embolizing something if we tried to poke at this aortic valve was just unacceptably high. I think transcatheter approaches when you have both aortic and mitral valves stuck is probably unrealistic. I think it's probably better if suited at this time, at least for patients with a single valve. Here's the fluoroscopy during her cath, just showing that the leaflets are restricted to both valves. And she went to surgery because we didn't feel that there was really any alternative for her here. This is one of her explanted valves. And if I recall, she got 2 bioprosthetic valves implanted. So I mentioned before, should you replace with a mechanical bioprosthesis? I think it is multifactorial. It's very hard to generalize. You have to consider the etiology of the thrombosis. And of course, this important question of whether or not the patient will or can take oral anticoagulation long-term. You've probably used and heard of this valve called the Onyx mechanical valve. It's a newer design. It is a bi-leaflet design. It requires a lower INR, which is attractive for patients. A number of studies have been performed with this, looking at different anticoagulation regimens. I'll just focus on this one, the PROACT mitral, which compared high dose and low dose warfarin levels and showed that essentially the low dose warfarin level was equivalent with no difference in the major outcomes of thromboembolism, valve thrombosis, and bleeding. So you can use these valves with a target INR of 2 to 2.5 versus the target INR of 3 for a mitral that is typically used with most mechanical valves. However, trials have been done with this, comparing the DOACs to warfarin. And the PROACT 10A trial was a randomized study and was stopped by the DSMB, the Data Safety Monitoring Board, due to an excess of thromboembolic events in the apixaban, the DOAC arm. So at this point in time, even with this latest generation, newest valve, you still have to use warfarin. You can't use a DOAC. So just to wrap up, and then we'll open to questions. This is our algorithm. We put it in our paper, and this is what we like to use at our institution. And I'd be very interested to hear your thoughts afterwards. So in a patient with a suspected mechanical valve and thrombosis, the first step, as Cesar walked you through, is to evaluate this. And I think multimodality imaging, it really is the way to go with echo, cardiac CT, and fluoroscopy. The next question is, what is their clinical presentation? This is what really drives the treatment algorithm and which path you go down. So in a patient who is stable, for example, this is a completely incidental finding, or their functional class is low, then the first step is just to ensure that they're adequately anticoagulated, and if they're not, they'll correct it. If they maintain stable hemodynamics, then it is reasonable to follow these patients as an outpatient, just to bridge them with, for example, low molecular weight heparin until you get their INRs back up, and then just follow with further imaging. But if they are not stable hemodynamically, or if they're the anticoagulation is actually already good, but they still have this thrombus, then we move on to the heart team discussion. Going back up to the clinical presentation, if the patient has hemodynamic instability, they're functional class 3 or 4, or they're in cardiogenic shock, then straight to the heart team discussion. And I want to emphasize the heart team discussion because I think it is about getting intensivists, imaging cardiologists, interventionists, and cardiac surgeons to put their heads together for these challenging patients. The heart team obviously has the choice between surgery to replace the valve, transcatheter release, or thrombolytics. Like we discussed, I think in most patients nowadays, the low dose, slow infusion lytics are the first line therapy. If any one of these is successful, then obviously you move to an outpatient follow-up. But if you start with lytics and that fails, then I think it's very reasonable, particularly if the patient is in cardiogenic shock and is unacceptably high risk of surgery, to try a transcatheter release. Although, again, it's important to emphasize these are still anecdotal case reports, and we need to learn more about these techniques. Of course, if lytics fail, then it's also reasonable to move to surgery, as we did in that last patient that I showed you. If the transcatheter release fails, then I think at that point, surgery is the only alternative. So just to summarize, mechanical valve thrombosis has variable clinical presentation, ranging from incidental finding to cardiogenic shock. Multimodality imaging establishes the diagnosis. The guidelines recommend heparin, anticoagulation, thrombolysis, and surgery, but I think, and the decision between these should be guided by clinical presentation and the patient's hemodynamics. Just to add to what is not in the guidelines, transcatheter manipulation can be considered when thrombolytic or surgical risk is prohibitive or as a bridge to surgery, but I just caution you to remember that picture of the basket from the Sentinel device. Pushing and poking around at thrombi on the left side of the heart is not without risk. We were lucky in that patient, although we clearly did dislodge some material. There were no clinical consequences, and the filter device captured what would have otherwise gone to the brain. But just be careful, and we're certainly not advocating that this should be in any way a first line. I think this should be reserved for patients who are really without other option. And with that, I'd like to thank you for your time and open to any questions.
Dr. Rogers and Dr. Cerza, thank you so much for your excellent lecture. We got some questions in the audience. The first one is about the transcatheter management, because it seems to me a novel initiative, and our experience with that technique in Colombia, I don't know if there's another of hospitals that implement that technique. I would like to know what technical conditions must be met in order to consider this type of therapy, specifically with respect to the thrombocytes, location. Is there any difference between right versus left bulbs, or some other characteristic that you have mentioned?
So first of all, I think it's very hard to generalize with any of these patients because the presentations can be so variable, the anatomy can be so variable, the location and the bulk size of the thrombus. And so a lot of this is simply common sense. That very last patient I showed you who had a mobile thrombus on one of her left-sided heart valves, I would argue that's probably not a good patient to try poking around at with catheters and a controlled environment of surgery with a patient on cardiopulmonary bypass to protect the brain from it and other organs from emboli is the much more prudent way to go. So I think I can't put sort of clear parameters on when to do a transcatheter technique, apart from the fact that there are only N=8 reported cases worldwide that we could find in the literature. I think it's patients really who are sort of stuck between a rock and a hard place, to use a colloquialism, meaning, the patient that we treated had supertherapeutic INRs, so we didn't feel that there was going to be much benefit from more anticoagulation. Patients in cardiogenic shock, the hemodynamics are terrible. The idea of just inducing them and trying to do surgery is considered unacceptably high risk. So they really don't have alternatives. But if we can get a leaflet moving, then we can improve their hemodynamics. And you saw in our patient how dramatic the hemodynamic change was almost on the end of the catheter once we got that leaflet moving. So I think it's very hard to generalize. You really do just have to treat these patients individually. And like I say, I want to caution you that I am certainly not advocating that everyone should get transcatheter release. I think it should be reserved for those patients where you do not have any alternatives. And I think more often than not, if it's successful, it should not be viewed as a definitive therapy, but it should be used to get them out of cardiogenic shock and get them to a situation and a hemodynamic status where surgery is now is safe to proceed.
Thank you. I'm agree with that. There's another question about this kind of initiative, especially the transcatheter technique. I want to know, is there any other therapy that you use with the procedure? I mean, it's something like an hybrid therapy. You just use the anticoagulation with the transcatheter technique, or maybe some patients do use with lytic therapy and the transcatheter therapy too.
I mean, I think that you often end up combining, or you often end up using, escalating sequentially. So I envisage that, in most cases, you would start with lytic therapy. If the patient is deteriorating hemodynamically, despite lytics and surgery is not an option, that's when I think there is a window of opportunity for a transcatheter technique to maybe get you out of trouble and get the patient out of the cardiogenic shock. So I suspect that these different approaches will often be combined, or rather they will overlap as you escalate from one to the other. I hope that answers the question.
Okay, thank you, doctor. And the last one is, I want you to know your opinion, because in our hospital we got a lot of pregnant patients with valvular heart disease, and much are then at porter of valve mechanic valves. Do you have any experience with this kind of patient, the pregnant patients, in the case of the thrombosis, these mechanical valves, especially with the lytic therapies? What is your opinion about considering Access as a management option in the pregnant patients, if you have the experience?
That's a really tough question, and I can honestly say I'm very glad to say that I've never had to deal with that situation of a young pregnant patient with a thrombosed mechanical valve who required anything other than just optimizing anticoagulation. There is it's completely a data-free zone. There are no guidelines on how to deal with mechanical valve thrombosis. Clearly, there are guidelines on how to anticoagulate patients at different stages of pregnancy, and those are well established. But again, I think you're going to just have to treat the individual patient in front of you and put together both the findings on imaging, the clinical presentation on that spectrum from incidental down to cardiogenic shock, and balance the risks, the benefits of the therapy. Cesar, do you have any thoughts?
Yeah, and Dr. Rose, actually, so if you go back to these thrombolytic regimen studies that you very clearly reviewed, I don't recall which one it is exactly, but one of the ones that you mentioned, it might be the Troya trial. There actually was a sub-study from those 100 or so patients that were studied in the bigger trial. They did a separate analysis for patients who were pregnant. Obviously, this is a smaller number of patients, but it actually showed 100% success in treating pregnant patients with thrombolytic therapy. So it has been shown, again, in small numbers. It was a sub-study of these 100 or so patients that were treated with thrombolytic therapy. But at least in that small study, it actually did show pretty successful parameters for treating your patients with this lytic regimen.
Thank you so much. One of our teachers want to make a question. Dr. Santiago, you go ahead with your question.
Okay, thank you, doctor. I want to make you a question. Do you have a specific size of the thrombi to represent a contraindication to the thrombolytic therapy, or the size of the thrombi doesn't matter at all? Thank you.
You want to take that one, Cesar?
Yeah, so at least from reading the different studies, I think the main distinction that was made was, and this is reflected a little bit on the guidelines, that if the thrombus is considered smaller, so typically that's thought to be a cutoff of 10 millimeters or less, then the thought is that those thrombi don't generally cause a lot of hemodynamic instability, and so those are treated more with anticoagulation alone. There is really nothing in the guidelines or on the studies that we mentioned that clearly state, when is there too much thrombus. And I think Dr. Rogers has alluded to this, that you really are guided more by the clinical picture, and it's a case-by-case basis in deciding what may be the best treatment approach. The papers that we highlighted really don't make any specific cutoffs for, a large or prohibitively large thrombus burden for treating with thrombolytic therapy. And again, with the transcatheter approach, there are only 8 patients that we could find in the literature that really highlight this option. And so I think it's not something we can really extrapolate from in deciding when you have too much thrombus versus, enough that we can really pursue a transcatheter approach.
And I think I would just add that so as an interventional cardiologist, we spend all our time thinking about how to avoid surgery. And just generally, we always prefer to gravitate towards less invasive medical treatments. But surgery is a great treatment if you have a thrombosed valve and you're otherwise fit for surgery, because it will obviously protect the brain and the important organs from embolization while the thrombus is addressed and the valve is removed. And you can, replace a mechanical valve with a bioprosthetic valve, for example, if the patient has issues or doesn't take their anticoagulation routinely. So I think it's important just to remember that surgery for many of these patients is the right treatment, and really the size and extent of the thrombus is I think irrelevant to most surgeons. Once they get in there, they can deal with anything.
Okay.
And I have a last question, Philip.
No problem.
Do you use the cardiac CT to evaluate the hands wall units to define who is going to get better with thrombolytic therapy, or is not a routinary action in your approach to these patients? Thank you.
I think it's a great question. It's a very interesting observation, isn't it? That the different Hounsfield units seem to sort of predict response or not to thrombolytics. I mean, I'll be honest, in our own clinical experience, thankfully, these cases are relatively rare. And I don't think I can possibly say that we've come to a point that we're using the CT and Hounsfield units to direct one way or the other. I think a larger multi-center study would probably be needed to see whether, to confirm that finding and to establish the sort of parameters that I think you're alluding that we'd all like to have to help better guide our therapy.
There is no more questions for the audience. Dr. Rogers, Dr. Sergio, thank you so much for accepting our invitation. We are very grateful for your message shared today, and also we can now adjourn today's session. And everyone, thank you all very much, and have a nice day, everyone.
Thank you. Have a great rest of the day.
Thank you for the invite.
Thank you. Thank you for accepting our invitation, Dr. Rogers.